Today we have a guest, Veronica Clapp, with us to help undercomplicate the topic of OCD or Obsessive Compulsive Disorder. Welcome to Undercomplicating Stuff, where we, two psychologists and coaches with over 40 years of combined experience, share our insights to help undercomplicate important topics. A friendly reminder that this video is meant for conversational and entertainment purposes only, so please see the information section of this video for additional resources. I'm Dr. Julie Radico. I'm a psychologist, a coach, an author, and a speaker, and I'm here with Dr. Stacy Gedian.
Thanks, Julie. I'm Stacy Gedian. I'm a health psychologist and the founder and CEO of a healthcare consulting and professional coaching business. And we're going to let Veronica introduce herself before we get started.
Hi, thank you so much, ladies. It's such an honor to be asked to be on the podcast and to be able to talk about such an important topic with you all. My name's Veronica. I have been a therapist now since 2013. And I have been specializing in OCD since 2020. So OCD is a specialty area of mine, as well as treating trauma, PTSD. Along with OCD, I treat panic disorder, phobias, generalized anxiety disorder, and depression. These disorders tend to go along with both OCD and trauma, which are specialty areas of mine. I also run a group practice, Veris Ridge Counseling in Burnham, Pennsylvania. We have 6 clinicians here, including myself, and they are a wonderful group, a variety of clinicians here that I'm honored to be able to work with. And so I have my group practice owner hat and also my therapy intensives hat for OCD and trauma.
Thinking about our listeners, one question that comes up really is what is meant by OCD? And how is it diagnosed? And what are maybe some symptoms that are common to it?
Yeah, so OCD, the biggest things that separate it from other disorders that involve anxiety. So we have the obsessive piece, that first word in the diagnosis. And so when you think about an obsession, we're not talking about like, oh, I'm so obsessed with, true crime or cats. It's not fun. It's not a good time. It's the obsessions, we also call them intrusions. And so if you think about a thought that comes into your mind or an image that feels very unwanted and yucky, it often plays off of maybe a fear that somebody has, a fear that they will do something inappropriate or that something awful might happen. And so we refer to them as obsessions because of how often they intrude. And so obsessions can take up more than an hour a day of someone's time, often quite a few hours. And in extreme cases, most of their day is spent navigating, trying to get these intrusive thoughts out. And so then we have the compulsions piece. And so the compulsions are basically any action, whether a physical act or a mental act, that the person does to try to reduce the anxiety and distress that the intrusive thought caused. For somebody that has contamination OCD, the intrusive thought or the obsession might be, if they touch a doorknob to leave the office, touching the doorknob, their OCD might say, oh my gosh, what if there were strep throat germs on there? And now you touched it and now you could get sick. So that's the obsession. The compulsion would be, I have to sanitize as quickly as possible or wash my hands. So while the compulsion can be something physical, it's not always something we can see. Sometimes it's a mental act, like saying a prayer a very specific way or a certain number of times, or trying to go over in your head why it's okay, or retracing your steps to see where you could have been contaminated. And so it's not always obvious.
Yeah, so what I'm hearing you say is that people with OCD can have obsessive thoughts and compulsions that other people might not notice, that like they might be really consumed with their thoughts and their worries and needing to say a prayer or do a certain mental activity to sort of soothe themselves.
Right, right. And so part of what makes the OCD such a difficult disorder to live with is when the person does the compulsion, which is aimed at soothing and minimizing that distress, it becomes almost like this addictive cycle where even though they just did the thing, OCD can creep back in and say, well, but what if you didn't get all the germs? Or what if that thing could still happen though? And so the compulsion only provides a very temporary relief before the person feels they need to do it again and again.
That sounds so distressing. I'm wondering if you could share a little bit about that. It feels like there's such a heavy weight on this, that it's not just, oh, I might get some germs and have a cold and feel uncomfortable for a couple days. It might be, oh, I might catch some germs, have a cold that then leads to like this life-altering or life-threatening sort of illness.
Well, and so it is different from person to person and live in so many different categories for people. And so when we're talking about illness, for example, someone could be afraid of getting a particular illness, such as the stomach bug. That's a really common one that people will talk to me about. They're terrified of getting a stomach virus, and it often comes down to the experience of vomiting. Like, it would be awful if I had to experience that. I wouldn't be able to deal with that experience, or how long might I have to tolerate it? But even within that, there's from person to person differences in what they find distressing about it. One person might feel that it's just disgusting and gross. For someone else, it could be, what if I do this in a public place and I'm totally embarrassed? And like those people never forget, and it's just seared in their memory for all time. And so other people might be more worried, like, what if I get someone else sick and I'm responsible and I caused that awful thing to happen? So even within one fear area, someone's OCD might fear something for a different reason than another person. And then we also have really so many categories where OCD can bother people. So we talked about contamination. We have scrupulosity or religious OCD, where even if you don't ascribe to a particular faith or spirituality, people might still fear that they accidentally worshiped the devil, or that they offended God, or that they're going to hell. And so OCD doesn't always follow logic. It can create fear, even if the person could say, I know this sounds ridiculous, but it's this physical sensation that comes over the body, and OCD has a way of convincing people of why they should be concerned. Yes, there's many, many different areas. We have the organization, things needing to be ordered in a certain way. With that, people can either fear that something bad would happen. We call that magical thinking. If things aren't just so, or just the way my OCD says it needs to be, then something awful might happen. Other people don't have magical thinking. It's just it feels so wrong to say, set the table and have the knife and the spoon in the wrong spot, that I just can't handle the sensations I get in my body and I have to fix it. And then we have OCD that can hang out in causing people to think that they want to harm themselves, which can be very, very distressing and confusing. People not understanding the difference between depression and suicidal rumination versus intrusive thoughts saying you want to hurt yourself with intrusive images of hurting yourself, but that's actually the furthest thing that you want to do. This is really what OCD is it's like whatever the person's value system is, OCD tends to take that and try to convince them that they are the opposite, or they are going to do something that doesn't align with their value system.
Thank you for sharing how many different types of OCD there are that can have the focus. And I imagine there's even more than what you've already mentioned so far. When you talked about those thoughts and obsessions related to organizing things, it made me think how often we hear people say, just in daily conversations, oh, I'm OCD about that, or he's OCD, or my friend is so OCD about that. And I do worry about minimizing the severity of something that is really a significant stressor for so many people, and wondered what you suggest we could do maybe a little bit differently, or ways to be a little bit more compassionate or aware that just saying those things, and we're not intending to hurt anybody, but they could be seen as flippant. Wondering what your thoughts are on that.
I'm glad that you mentioned in there, yes, there are many different other categories of OCD. I definitely did not give you an exhaustive list, and those were just a few examples. But yeah, I've heard comments like that too. And I know that people don't mean to be hurtful. OCD is extremely common. There are millions of people in the US that have it. And so there is a good chance when we're out and about that someone around us might have it. And so it is important to remember that it is a lot bigger than just liking things a certain way, that it is a clinical and highly distressing disorder that can really shrink people's lives and really feel debilitating to them. And so if someone is particular about something, that can be very different from them actually having the clinical diagnosis of OCD. And so I think that awareness is really important. And we might have our different things that we're particular about or that we like a certain way. And I think we can describe it like that and leave OCD out of it unless we truly were diagnosed with OCD and we decide that we're going to disclose that to someone and that that's part of it, then, I think that would be appropriate.
Building on that, I'm really curious in our conversations day to day, what also might come up that really touches upon like myths of OCD? Like, what are things that people tend to believe about OCD that aren't necessarily true? Which I feel like touches upon this idea that we might say, like, oh, I'm so OCD when we like things a particular way, but don't really understand what OCD actually means as a diagnosis. Like, what are some of those myths that you feel like are out there?
Because OCD is not super well known about, people tend to believe that it's what they see in the media, right? And so we've had some TV shows and movies that are really heavy on displaying it as like the contamination, right? Or things having to be exact. And while those are criteria where OCD can show up for people, there's just so many more criterion than that. And having OCD doesn't mean that that stuff bothers you at all. People can be terrified about showing up as an imposter or that they're not actually qualified to be in a place that they're in and that they're going to be like found out. Their OCD can kind of be in all different categories or it can kind of specialize in an area. But I know many people with OCD who are not neat freaks, who are not, things have to be just so, and they're not worried about germs at all. So I think that's a huge thing that like when you hear about someone having OCD, I would get curious if they're willing, if they're sharing it with you. Don't just assume you know what that looks like for them. It could look very different. People might not realize how common it is. And so 1 in 40 adults currently have OCD in the US and 2.2 million children. It affects all races, all cultures. And so it's not like, just a man thing, a woman thing. Like it's, anyone can have it. And it takes people about 7 years or sometimes longer to receive an accurate OCD diagnosis. Even among clinical professionals, there are so many mental health conditions out there. We can't be specialized in all of them. I know before I got trained in OCD, I actually think back to cases where I'm like, oh, I missed that. Because when I went through my training, I remembered people who I had diagnosed with generalized anxiety. And I was like, oh, if I could go back. But until you have the education and the training, it can be really easy to miss and to not be asking the questions to find out if compulsions are happening. Sometimes people don't even realize what they're doing is a compulsion. They don't realize that this isn't normal, or there can be a lot of shame around the obsessions and compulsions. And so often people won't just come right out and share because they're afraid that they'll be misunderstood. Another one, that they could just cut it out or that they're just not trying hard enough to stop. And so the condition often wants close loved ones to accommodate it. OCD can be very bossy, right? So for example, if someone's obsession is that something awful is going to happen to my loved one, they might demand, I need you to have your location on so I can check it at all times. And if you're not in a place where I expect you to be and I text you, you need to get back to me immediately and explain where you are, because otherwise I'm going to be riddled with anxiety and fearing that you were hit by a car, because the intrusive thoughts could cause these really upsetting, startling images that comes with this awful feeling of dread. The person becomes convinced that this is really happening. And so OCD can kind of draw people into the compulsions and try to make them participate, which can become frustrating for friends and family members who aren't feeling this themselves and who feel like, why would you jump to that conclusion? Because the OCD is not happening to them. And so you hear things like, I really need you to just try harder or just like cut it out. And if it were that simple, then people would obviously do that. But the treatment is difficult. It's very, very treatable, but the treatment of choice, which is exposure and response prevention, is encouraging the person to actually lean into their fear, since that is kind of counterintuitive and very difficult for people to do. Often before they seek treatment, they're asking for a lot of reassurance from loved ones and family members. And while that feels like the right thing in the moment, that's actually colluding with the OCD in the long term and kind of making the OCD stronger. And no amount of reassurance is ever going to be enough. There's no amount of the right logic that's ever going to convince the person, oh, you're right. Like, I don't have to worry about that anymore. They might say, okay, I feel better right there with you, but the intrusion will just come back later.
You can sense how frustrated people might be because they don't experience it and it simply just stop doing that. And of course, it's not that easy. You mentioned
Right.
that the treatment of choice is exposure and response prevention. Can you say more
Mhm.
about that and how that might work and maybe even a common example?
So, exposure and response prevention is otherwise known as ERP or EXRP. It's a evidence-based treatment. It's been around for many, many years. And I love it because it's a very simple concept. We're helping people to face their fears. So, many of us have learned how to ride a bike without training wheels. And in order to do that, I know for myself, my dad had to push me to do this, right? He had to practice with me. And for me, I experienced a fear of falling. And if it were up to me, I might have just said, I don't want to do this. But because my dad believed in me and pushed me, we kept practicing. I learned how to ride a bike without training wheels. So many of us can grasp and have seen this where we're afraid to do something like maybe public speaking. And if you avoid it, your fear of it is only going to grow. But the more opportunities you take to practice it, the more natural it becomes, the better at it you get, and you might even have fun doing it. And we can see the same concept with a scary movie. So we could all watch the scariest movie we've ever seen and all agree that was awful. I never want to watch it again. But if we did watch it every day for a month straight, probably by the end of the first week, we already would be very desensitized to the images. I would be saying, okay, this is starting to get a little boring. I'm ready to watch something else now. It's not having that same fear response. Since OCD has its own skewed logic and we can't out logic the OCD, what we do is we prove the OCD to be wrong through repeated experiences that kind of get us to find out, okay, is my fear really going to take place or not? So here in my office, if I had someone doing exposure therapy and they were really terrified of germs, then we might do an exposure of going around and touching doorknobs and then not washing and not sanitizing. And I do this with my clients. Any exposure that I ask them to do, I'm absolutely doing with them. And so, we would touch as many surfaces as they feel they can handle. And then we sit with that and we sit with, okay, whatever's on my hands is just on my hands now. Sit with that for the whole counseling hour. And then I would encourage them to go as long as they can upon leaving and not wash. And then that's their homework is we might have a prescribed amount of times that they allow themselves to wash in a day and not to exceed that, with the goal of we're decreasing the hand washing until we're only hand washing after like you actually use the bathroom or feel something sticky or see something gross on your hands. Like your senses are telling you, I see that I need to wash them.
So it sounds like you are helping them build evidence to disprove these unhelpful beliefs that they might have, these like unhelpful thoughts that are coming up. So I wonder if there are other strategies that you could share with us that you help people to learn during this exposure therapy for those moments when they've touched something that they feel like might be contaminated, and then they're trying to sit and build that evidence that they're okay without washing their hands or using hand sanitizer. Is it encouraged to do some sort of like self-soothing, and what might that sound like? Or is it more so to just like sit with the worry?
With self-soothing activities, we have to be careful because we want to make sure that OCD isn't going to try to use it as a new compulsion. And we also want to make sure that we're not giving any reassurance, because reassurance seeking is such a huge compulsion. We don't want to lean into anything like, I'm sure I'll be fine. Or, oh, like, I don't actually know if there was anything bad on that doorknob, because that's the reassurance seeking starting. We don't want to feed into that at all. And so usually with ERP, it's, hey, I'm right here with you. We're doing this together. And we're going to find out what happens. And usually what people find is actually the worst part of the exposure is the lead up, when you know you're going to do it and you haven't done it yet. convincing themselves to do it. And so we usually say, like, hey, less thinking, more doing, because if you let yourself stay in that thinking, you'll probably start to ruminate and you might talk yourself out of it. We agree first on the things that we're going to be the challenges that they're taking on. And then we're okay, if you feel ready, we're going to do it. We're going to rip the Band-Aid off together, and I'm right here with you. And so I think it would be fine for someone who's having a lot of distress around this to do some breathing exercises, so breathing with the square, 4 seconds in, 4 seconds out, hold, breathe in for 4, hold, out for 4, hold, restart. And a really good one is honing in on your senses, right? So how do my feet feel pressing into the floor? Is there a pen or something that I can hold in my hand and notice the different textures of the pen? Are there any smells, particular smells in the office that I can notice? What sounds can I notice? So just rooting and grounding like I'm here and noticing some neutral stimuli in the room. So I think we can do that without giving reassurance in that. The key really with ERP is people are learning how to lean into uncertainty and accept uncertainty. So OCD always wants to be certain. It wants to know all the things. And so there's just so many things in life that we as humans can't know. And so we want OCD to kind of see that. And the best way to do it is we practice doing the thing and then we just find out. And the more we practice it, the easier it becomes to trust that, okay, just because I did something and OCD said a scary thing would happen, now I'm getting the data that that bad thing doesn't always happen. And let's say that someone does actually get sick from this or get sick after this, and maybe they say, oh, I did the exposure and now I got sick. So oftentimes that doesn't actually backfire because the person learns that, okay, I was able to survive that.
They're able to prove to themselves that their worst fear was maybe realized and it was okay.
And that's one of the things I love about the treatment is that it builds feelings of competence and confidence. And so people are able to expand their world and do things that maybe before they were limiting themselves because of the fears that OCD caused.
I can imagine how rewarding that would be to see people literally have their worlds made bigger through treatment.
Yeah.
You had mentioned earlier that it's really common. 1 in 40 people may meet the criteria. And I'm wondering if you have a sense of what are some risk factors or contributing factors, precipitating events, genetics, what it might be that might make someone vulnerable to developing OCD.
I don't totally know a cause. There are theories, but there's not like a definite answer to what causes it. In my practice, I see that it often runs in families. So if a parent is bringing in their child for treatment, it's not surprising. I've often seen where the parent has it too, or someone else in the family does. And because families don't always know, when I'm talking to someone and asking, does anyone else in your family have anything that presents similarly, they might be like, oh, well, the families might label it differently, like so-and-so is a worrywart. And everybody knows that she's always worried, or so-and-so, she doesn't like to leave the house a lot. Maybe this person has never really sought out formal diagnosis, or the family just kind of accepted this is how this person is. And so I do tend to see it run a lot genetically. That doesn't mean that if you have someone in your family or a parent that you're definitely going to get it. I'm not sure exactly how the cookie crumbles with that. But it does seem like the onset of OCD, which can happen at any point. People can have the onset when they're a kid. Sometimes it happens after the birth of a child. I've had people tell me, it was after the birth of their second child that their obsession started. And so it can feel kind of random and not the same for everyone when they experience it, but they had the gene for it. They had the predisposition for it in the brain already, but it's not something that someone can cause. So I've had moms who have had their OCD that kind of shows itself with their kids and maybe making their kids have to take shoes off before coming in the house or making kids wash their hands very frequently and then worry oh no, did I give my kid OCD by modeling these behaviors? And you can't do that. You can't make someone get it, or it's not contagious in that way. Those behaviors could be modified and it might not look the same for that child as actually having the OCD.
So this conversation has been amazing at giving some really concrete and helpful information to demystify what OCD actually is, because we use the term so much in our just regular conversations, and it has so much nuance and different layers to it that hopefully this helps people get a bit more understanding as they continue to explore. My key takeaway as we think about this is the avoidance piece in this, and
Mm,
that to really not avoid dealing with OCD if it is something that is present in your life, but also the layers inside of that, that what OCD is trying to get you to do is to avoid, is to do some sort of behavior that is in a way avoiding something bad happening, but also avoiding just letting yourself potentially have contamination on your fingers and let it sit. It wants you to avoid proving to yourself that you would be okay doing that. And so really hoping that people take away just being aware of what is it that you might be avoiding in your life, and if OCD is part of that, to really reach out for help, to start to notice those patterns and to know that you're not alone, that there's some good evidence-based treatments that could help.
yes, that's huge. I think that's a really important takeaway. I know that avoidance, it really is the opposite of healing. And it feels safe. It feels like, okay, I've cushioned and protected myself. But we notice we're shrinking our world and there's less and less things we feel we're able to do. It really stinks, and there's things in life we could really enjoy. It requires that leaning in and facing that fear component, which is really tough. Really tough. So I have so much respect for people that go and do ERP or other forms of treatment, right? It's not just ERP. ICBT, inference-based cognitive behavioral therapy, is another wonderful treatment that I also offer. If people are like, nope, exposures are not for me, don't want to go that route, ICBT is another way to go that is not exposure-based. It does a lot of teaching about OCD and how the OCD sequence goes and learning how to stop the sequence before you get to the compulsion part. There's also SSRIs that can be an option combined with therapy that can be really helpful. It might feel scary to do it, but there are options. I would look for an OCD expert in your area. And so I know IOCDF, the International OCD Foundation, has some great resources. NoCD also is a website that's all about OCD resources and OCD specialized therapy. But there are many of us therapists who are trained and specialized in OCD. So researching to make sure that you find someone who knows the condition.
Since we're talking about the treatments and how to find someone, my key takeaway is going to be asking what your key takeaway is and hoping that you might draw upon your experience of what someone maybe shouldn't say to a loved one or someone they know who might be experiencing the symptoms and what they could do instead to encourage them.
This is really tough. I know most loved ones really want to make their person feel better. And when someone's upset, for many of us, a natural go-to to be like, no, these are all the reasons why it's okay. These are all the reasons why that probably won't happen. And I think it's important to remember that that feeds the OCD. And so they might experience temporary relief from that, but they'll just start worrying about it again in a little bit. And so the reassurance is really not helping. It would be better to offer, hey, I'm right here with you. And I'm right here with you in that. And then you can ask, what might be helpful for them or what they need. Maybe there is something like, hey, can we go on a walk together? There might be something that helps them not put their focus on what the OCD is saying to them. Like, hey, could we maybe do another activity that helps us refocus on the present moment and not put so much focus on that? And that's one of the ICBT methods, is making a hard shift, kind of a grounding shift of what do I want my focus to be on, and let me go in that direction. But I will often tell people, have them kind of talk with their family member, like, in what way can they gently say, hey, is there any chance that I might be talking to OCD right now? Does this feel like you, or does this feel like this might be OCD? And that's in cases where they've disclosed to the person, like, I have OCD, this is something I'm struggling with. And so I like to tell the person with OCD, hey, talk to your family or your close loved ones about how they can gently ask you if this might be what's going on. Because that might help the person realize it themselves. Like, hey, this doesn't really sound like you. This sounds like this could be something else. It's always, hey, can I sit in the unknown with you? That's what I'm doing in my therapy sessions when people are doing ERP, is I'm saying, hey, I'm willing to face this with you. And if something happens, I'm right here with you. And
I think that's a beautiful sentiment for us to close up this conversation on. So So if this topic resonated with you, please share it with somebody that you care about. Also, please comment, like, and subscribe. You can listen to our podcast on YouTube, Spotify, or Apple. You can also message us on YouTube, Facebook, or LinkedIn with questions that you'd like us to discuss in future episodes.